rotation. Okay, so enough about me. I'm just going to dive in now. All right. So medical record keeping. I've kind of made this presentation based off of standards that have been developed by the GMC. They've outlined these standards in Good Medical Practice, published in 2013. So that's a good reference. Essentially, records, whichever form they take, be it in letters, in history sheets, in consultations, in blood forms, whatever they might be, essentially are a useful reminder of a course of events, required actions, the steps that have been taken, the outcomes out of those steps taken, and whatever plans or further actions that have been planned. Okay. The GMC states very clearly that your documentation must be clear, must be accurate, and legible. You have to report relevant clinical findings, decisions that have been made by yourself, your team, when those decisions have been made, whatever treatment has been administered as well. I think the key or the most important thing here is to remember, always remember that your documentation is a legal document. So in the event of, a complaint is being filed or a claim also has been filed, those documents can actually be used as evidence in cases. Okay. So it's just to kind of keep you on your toes, to remember that whatever you do write not only will be, read by other members of staff, nursing staff, therapists, discharge coordinators, your consultants, your colleagues from other departments, but in the event might also be read by the patient themselves or legal teams. So again, what is the aim? Why the fuss? Why the emphasis on documentation? Documentation. I know across the board, you guys have experience either from medical school or in your own practice up until now, and you've been documenting. So why the continuous fuss about documentation, especially in the NHS? So there are certain standards that need to be met each time you kind of make a documentation as it pertains to a patient. Okay. The essence of medical records or documentation is a reminder. It tells you, what happened during that consultation. When you saw that patient, what happened? What was your impression? What did you do? What did you plan to do? And what's going to be done? Okay. It informs your colleagues who might see the patient in the future. This means if that patient comes back into hospital, it's very likely that you or your colleagues will look back on your, previous documentation, and that's going to give them a lot of information about that patient. One kind of quite practical example I can think of is in stroke. If we do discharge a patient, let's say a patient's come in with a left-sided stroke, they've got weakness on that side, they've had physiotherapy, occupational therapy input, and we discharge them home. If they have another stroke coming in, looking at your past documentation is a very good kind of measure of how much did that patient improve. So if they do come back with another stroke, how much worse is it? Without, kind of a very clear documentation of that, it's hard to gauge. So in essence, that does affect your patient care, and that is the end goal, to make sure that your standards are high, so that you're looking after your patients to, the best of your ability, really. um Records can be used as evidence, like I mentioned earlier, and also if the standard of your care is ever put into question, you know oh, why was this done, why was that done, anyone looking at your documentation should be able to kind of see, okay, what happened? What was the rationale behind that? What was the outcome? So that there aren't any question marks. Okay. So next slide is just on generic medical record keeping standards. Okay, these standards were developed by the Royal College of Physicians, based off of good medical practice from the GMC, and they essentially outline things that have to be maintained in the records. Before I carry on with the slide, just to mention with the NHS, so you have in different trusts, you have either paper records or electronic records. Now, for the electronic records, you have systems such as PowerChart or Cerner or other systems I might not be aware of, but those are the ones I've come across. And although you document everything on the system, you type in everything, you log in there, and usually you can, document your consultations, your letters, your prescriptions, your referrals. It still follows the same standards because at the end of the day, you have to type in something and you have to record what has happened. At the moment where I do work in Broomfield, we use majority is paper kind of based, but things such as discharge summaries, online requests, and things like that are also mostly electronic. So it's kind of a mix, but patient notes are paper. Okay. So just on the medical record keeping standards, all right. So the first one, which is quite important, and you will notice when you're on the wards, the patient notes should always be with the patient. So the complete medical record should be available at all times. If a patient goes for a scan, the notes have to go with the patient. That being said, that's because in the event of a medical emergency, for example, you need that information as close to you, as possible. So even in trusts where maybe most things are electronic, you might have some sort of kind of paper record, even if it's in the form of a ward round sheet or a ward sheet where you have each patient listed there and their problems and things like that. Okay. Um, every page in the medical record should include the patient's name, identification number, and location in the hospital. So again, this is, I would say, a compulsory standard, and it's quite difficult to miss this. But obviously, in different situations, it is possible to be missed. My first telling off in the NHS was exactly because of this reason. So I had a conversation on the phone with another department regarding a patient, quickly documented and ran off to do something else. I didn't put the patient's details at the top of the page. That, especially when you have paper notes, the rationale or why the fuss is if that particular page, for example, gets ripped off or gets lost, you don't know who that was meant to be for. In electronic kind of documentation with PowerChart or Cerner, usually once you log in and open up that patient's records, then you're on that patient's records. But it's also important that you always check not only the patient's name, because you do find sometimes patients have similar or the same name. You check the identification number or and their date of birth. Okay. Data recorded or communicated on admission, handover, and discharge should be recorded using a standardized proforma. So we have different performers that we use in the NHS, be it a clocking performer or discharge performer or ward round sheet. Essentially, what that means is it's a specific document for that reason. Being if it's an admission kind of performer, then it has a certain structure. Now, in most hospitals, they sort of use this a similar pro forma for that. It may differ from trust to trust, but the structure of it is pretty much the same. So if you're working in A&E or in medicine in most hospitals, you will have like your own clocking pro forma, even in surgery as well. So it highlights the important bits regarding that specialty which you need to document. if you do kind of diligently fill out those performers, then it's very hard to miss any details that are important in, admitting that patient. Documentation should reflect the continuum of patient care and should be in chronological order. Essentially, what that means is if a patient has been in for, let's say, a week, if I read the medical notes from day one to day seven, I should understand the history of what's happened. I should see the progress of what's happened and kind of understand everything that's happened in that patient care. The flip side of that is if you have very poor documentation, which is, sort of one line entries in your day-to-day ward rounds, then you don't really know what's gone on. Has the patient had a CT scan? Did the patient have antibiotics? Did the patient become ill? Was there a medical emergency? And if those things do occur, then it's very important that you do document. The point is, if your colleagues come on shift, if you go off shift and your colleagues come on shift, they should be able to read those notes and understand everything that's gone on with the patient. Not, you won't always be there to give a verbal handover, which we do give, verbal handovers. For example, when you're going off shift, if you're on call, but even day to day on the ward, if you refer a patient to another kind of specialty and they come to see the patient, you don't always have the time to then talk them through everything again. Sometimes they even just prefer to kind of go through the notes because you might forget something. Our memory is not the most reliable, so you write down everything and then that kind of eliminates the chance of forgetting important information. So entries in the medical record, basically in patient notes, you should document things as soon as they happen. So if the patient, for example, you've done a ward round, normally we document on the ward round. So you don't wait till afterwards because you need to be documenting, how's the patient today? What was the examination? If did they have a scan this morning, document that as well. If you've had a discussion with the patient, document that as soon as possible because those details are still very fresh in your mind. The longer you wait, essentially, the more things you might miss out. Also, the longer you wait, that increases the chances that key information that you might have might not be accessible to the rest of the team. Rest of the team being, even the nursing staff, the patient themselves, if they come and ask the staff for something or your colleagues. Okay. If the patient has a change in, their clinical state, if they deteriorate and, the nurses run up to you or bleep you and say, Doc, can you, come review this patient? They're unwell. You review them, you have to make an entry. If you've had a discussion with the family as well or with the patient, or you've made any change in treatment, essentially any significant event or any review by the doctor needs to be documented and documented clearly. When you do document, you should list at the top of your page the most senior healthcare professional. I have a few examples at the end of the presentation, just kind of some visual examples as well, just to see the structure that I'm talking about. But essentially, if you're doing ward rounds, you write your date, your timestamp, who's who's the most senior healthcare professional leading that ward round or leading that review. If it's your registrar, you write their name. It's good practice to write each team member's name that has attended, that consultation or that review, but it's not always practical. Sometimes when it's, you have 28 patients to do a ward round on, you can't write Tom, David, Sarah, and who know, who else for every single patient. The most important is the most senior healthcare professional, and if that's the consultant as well, that should also go on the on performer, essentially because that patient is under the care of the consultant. Okay, so if, for example, the consultant changes, if the patient goes to a different ward or is now taken over by a different team for their care, then the name of the consultant who is now in charge of or for the care of that patient should also be documented. It's also a legal issue. It's also, good practice just for people to know who is actually making the decisions for this patient or who's responsible for this patient. Okay. And last but certainly not least is discharge records or discharge summaries should be started at the time a patient is admitted to hospital. Now, this is ideally good practice because when a patient comes in, if you start the discharge summary, essentially you're keeping the information up to date, meaning that at the end of their stay, you would have a comprehensive discharge summary and you wouldn't miss anything. Practically, what does tend to happen, and this can be down to staffing pressures or time, or just your share workload at the time. You do a discharge summary at the end of the patient's stay. If it's a 7 day stay or a few days stay, those are relatively easy. You go through the notes and you have to document what's happened, what decisions were made, what were the outcomes, what plans have you made, going further, and that gets sent to, you give a copy to the patient, you give a copy to the GP, and if the patient has to come back into hospital next time, those records are easily accessible for the team as well. In cases where, in my experience anyway, where you have patients, especially in elderly care, that have stayed, in hospital for, let's say, a month or 2 months, if the discharge summaries are not started at the beginning, or at least at some point, in the beginning of a patient's stay in hospital, then you, as the doctor doing the discharge, you're left with heaps or 2, 3 volumes of patient notes that you have to kind of skim through and get the important information out of. Okay. Anyway, if anyone has any question, just feel free to ask at any point. Okay. So the next slide is on recording a consultation. So if you do have a consultation with a patient, this being in clinic, on the ward round, what exactly do you need to document? So as junior doctors, when we do, for example, a consultant-led ward round, you will generally be in charge of documentation. What that means is you, again, date, timestamp, who's leading the ward round, and then you have to write what goes on the ward round. Normally, what happens is we get in a bit earlier and we prep, observations for the day, any relevant investigations that have been done up until then, and then we go for the ward round. And whilst the most senior person is reviewing the patient, we document. Important part of that again is making a plan at the end. So, in summary, you need to include relevant history and examination findings. So, if a patient comes into you from ED, what's their relevant history? That's going to be, how old is the patient? For example, 36-year-old male, what's the presenting complaint? Shortness of breath, chest pain. History of the presenting complaint. It's a 3-day history, intermittent pain affecting his daily life, has taken analgesia but to no effect. Basically, just you flesh out the presenting complaint itself and any relevant information. Next thing would be, examination findings. So, have they had a chest X-ray? Have they had bloods? Have they had a CT, COVID swab? Those things are important. What are their observations? Your examination as well. What have you found on your examination? So, the essence, once you've gotten like a history, you've done your examinations, you've done your scan and different investigations. What's your impression or diagnosis? You might not always have a diagnosis at that point, and that's when we use, the term impression. So, is your impression maybe likely cholecystitis, or likely chest infection, for example, likely sepsis? That means that you have a working diagnosis, but you do start, your treatment, and you make a plan. Essentially, if you word it in that way, whoever's reading your notes then is kind of aware that, oh, okay, they didn't have a definitive diagnosis at that point, That was their impression, that was their working diagnosis, and that's why that kind of justifies your plan then. If you do make a differential diagnosis, then you should also document, what have you done to exclude that differential diagnosis. So if a patient comes into you, for example, with chest pain, one of your differentials is aortic dissection, for example. That's a very serious differential diagnosis. Even if you have excluded that, with a scan, you should document, because in retrospect, if there's an adverse outcome, for example, and someone pulls up that documentation, in essence, even though maybe you might have gotten a scan, there's no written proof at that time, what was done then? What was the outcome of that? How did you exclude that? If that makes sense. Okay. And at the end of your documentation is usually where you're going to see a plan. So we just say plan, and then you highlight, continue antibiotics or comment on this treatment, whatever plan you've made. Also, discussions with the patient or information given to the patient is also documented there. Any investigations or referrals, is good practice to document those as well. And usually, if those are done, it's good practice to come back and, document. If you said, let's say, a respiratory referral, it's good to say sent. Or if you send a written referral, print it out, put in notes. Again, the essence is, as you're treating the patient, as you're taking care of this patient, your documentation should reflect the patient care, so you should be aware of, what's going on, essentially, what has happened, what is going on, what's the current situation with the patient. So information given to patients, different treatment options. So usually you would discuss with, with the patient, for example, in maternity, about, let's say, a vaginal birth, or a C-section, for example, and you could just explain, to them these different options, and that should be documented as well. Because again, don't forget, this is a legal document. Okay. Safety netting is quite important. Essentially, that is when, you the prognosis or how that patient's illness will progress is not very clear. So, for example, in my practice at the moment in maternity, if we have a pregnant lady coming in with some bleeding, we've ruled out, sinister causes, she's stable enough to go home, we safety net them, say if your bleeding continues or if you have any concerns, if you feel unwell at all. Symptoms is kind of giving them red flags to look out for. It covers the patient in a way that they look out for these symptoms and they're able to come, to hospital quicker. And it also covers you from a legal point of view. Okay. And also, don't forget the date and time of each of these entries. So just some other things to include: any phone conversations that you do have, always make sure you get the name or role of the person that you speak to on the phone. If you discuss with another department, document it. If you discuss with family over the phone, document that as well. Any test results, document that. If you've got referral letters, written referrals, you can either print them, stick them in the notes, or, make an entry that has been acknowledged. Okay. Any family discussions or updates as well, you need to document. With family discussions and updates, those, even if those are quite long conversations, you don't need to document every single word of that conversation. You essentially just need to, what was the purpose of the conversation? What did you explain to them? What were their concerns? And what was the outcome of that conversation? Okay. So just going on to, now that I hope we've gotten that idea of, why documentation is so important, how to document, or kind of the standards that we should keep. Before we go to the examples, I just want to touch on some common abbreviations. So these are one thing in the NHS when I started, and I'm sure a lot of my colleagues have the similar experience. The the sheer volume of the abbreviations is can be quite overwhelming, and it changes from specialty to specialty as well. But there are certain abbreviations that, kind of they stick with you throughout your practice because you keep hearing them over and over again. Um, so we tend to use arrows for increase, decrease, any accident and emergency. ABX for antibiotics. I'm just going to touch on a few. DIB, difficulty breathing. Again, a lot of you might know some of these, but just for it's good to be aware of other ones as well in case. DNER or DNECPR is, do not attempt resuscitation. D/W, this one kind of twisted my head a bit when I first started. Discussed with. G and S, group and save. Main, I must admit, I only found out what this one meant recently, but it means in the morning. So you see, nursing entries a lot saying something, something main, talk main. MCNS, that's microscopy, culture, and sensitivity. News, national early warning score. TTAs. I think the previous presentation our colleague did touch on this. So TTAs, TTOs, you hear this a lot. Doc, patient is going home. They need TTAs. When I first started, nobody knew exactly what it meant, but everybody knew, what it meant. It means on your discharge, you need to do the medications for the patient to take away or take out or go home with, essentially. MSFD, MOFD, that's also something you're going to be hearing a lot. So when a patient is deemed medically stable for discharge, that's the point where we start getting everything ready for them to go home, essentially, meaning their drug charts, so medications to go home with, discharge summaries, arranging outpatient or follow up investigations or appointments for them as well. So talk as well is trial without a catheter. PRN, pro renata, which means as required. So if they ask you, doc, can you prescribe some PRN paracetamol? It means prescribe it on the PRN side of a drug chart, or electronically you would be able to slot in, a PRN so the patient can take it as needed, not regularly. Okay. And of course, as you guys I'm sure well know, once a day, BD for twice a day, TDS 3 times a day, and so on. So coming to kind of the end of the presentation, we have different types of medical records. So medical records could be the clerking performers that I mentioned earlier. It could be a ward round performer, which is essentially a blank sheet of paper. It will usually have your trust logo on one side, a space for you to kind of timestamp date and time, and the rest is blank for you to document. Discharge summaries, these are usually done electronically, even in paper-based trusts. I think in the odd occasion you have to, do it manually, not on the system, but I haven't encountered that. Discharge summaries are essentially a letter to the patient slash GP, especially addressed to the GP, informing them that, dear doctor, so and so patient was admitted to us for X reason. This is what we found when we investigated. This was our diagnosis. This is what we treated the patient with. We're sending the patient home with XXX medication, or we are changing so and so medication. We've arranged an outpatient follow up with us in maybe 3 months. Kind regards. And that's all you need to say. So they know why the patients come in, they know what happened to the patient during the stay, relevant information being medication changes, because here the GP would then have to incorporate those medication changes and give the patient regular prescriptions from then on. So they need to know why was the medication changed, which goes again to accurate documentation. Why was it changed? When was it changed? And what's the plan going forward? You've also got clinic letters. So when you see patients in clinic, you draft or you write a letter or dictate a letter that goes again to the GP and to the patient as well. Written referrals are between specialties. So if you need the gastro doctors to come see, you have to usually do a written referral. In some trusts, it's just a verbal referral. So you bleep them and you can refer over the phone. That is down to the specialty and down to the hospital, depending on the system. In Basildon, for example, most of our referrals were paper based. So you would have to type out a referral, send it at one point fax, but luckily just email it now and then the specialty picks it up, triages, and then comes and sees your patients. So other types of medical records, um, which are not you use them every day, but they're not, where you write your ward rounds. However, they are equally important because these are again legal documents that have to be signed, filled out correctly, again for patient safety. Top of that list being drug charts. I know you had a bit of a look at drug charts with the previous presentation, but documentation in drug charts is also very important. It's a sort of etiquette, and if you keep yourselves to those standards, you avoid mistakes that inherently affect the patient. Okay. I have some examples I will touch base on with you guys as well. So you've got blood forms. There's a lot of paper blood forms as well. Some investigation requests have to be written. Peace documents, these are proactive, enhanced, advanced care planning. You come across this in your practice. Consent forms, for example, for surgical procedures, self discharge forms. If a patient wants to leave on their own, they have to sign that. You have to sign that. VTE forms as well, which is venous thromboembolism forms or prophylaxis forms. Okay. Okay, so coming to the end now, I've just got some examples just to kind of show, what's the standard, what's the classic examples, and how you should or what you would be expected to do as well. So this is a very classic example of a ward round entry. On the left, you've got, so here I haven't got the patient details, but that would usually be at the top of the page. On the left hand side, you've got date. The timestamp is usually using a 24-hour clock. And then to begin your ward round entry. So, what is the entry? Is the first question, right? So, ward round, who's leading the entry? Mr. Sutcliffe, and what's that person's designation, which is SPR or specialty registrar. Okay. Then you go on to, as a ward round, if the patient is known to you, you should have already some information about the patient. So in this case, this is a day one post appendectomy patient. Currently, the patient is pain free, slept well overnight, no nausea or vomiting, good urine output. Next thing is your observation and examination. And again, this is generally the structure that you'd be expected to adopt. So what are the observations? Next thing, your examination, which this is, standard examination of the abdomen. They've written down their findings, and then the plan. So your plan, if the rest of your entry is not legible, please make sure your plan is very clear in your grammar, in the plan itself, and also clear in writing. You might know the plan, but the nurses need to look at your plan. So, if, for example, on some wards, if you say bloods today, it would be down to the nurses to do them. So, they need to understand what you've written. If you say CT scan later today, or so and so procedure later today, other members of your team need to be able to understand what you've written. It's very common where we come across, let's say another specialty has come to review your patient. They've documented in notes as they should. You come back and you can't understand a word of it. I've had cases where I've had to call them back and literally ask them, what have you written? What's the plan? Because unfortunately I can't understand what's been written. Okay, and then to close off that entry, you should stamp your name. So who has documented? You write your name, your designation, in this case, J. Smith. Designation is an F1, and then they've put their bleep. So you need contact detail. This is very useful because, for example, if you're off the ward or you've seen a patient in A&E and you've left to see another patient, if the nurses need you for something regarding that patient, or if your colleagues need to contact you to discuss the plan you've written, how do they contact you? So if you do have a bleep, it's good practice to put that just so you can be contacted. Okay. These other examples are, so on the left is a referral letter. It's quite long, so I'm not going to read through it. But they've addressed it to the appropriate person. Patient details, very important. So name, date of birth, identification number, problem list or the diagnosis. So they've listed the diagnosis and then they've carried on to kind of explain what's happened, the patient's background, drug history as well, social history. Okay. That's a very nice, good summary. So if you're seeing a patient and you go through the letters and you come across this referral letter, this is actually a beautiful referral letter because it gives you all the information that you need. You're not left guessing, oh, but how about this? How do I get that information then? Okay. On the right is again is a ward round. One is a ward round entry, and the rest are just kind of different entries made in the medical notes. And this is generally what the medical notes will look like. In between, of course, you have nursing entries. But these are, entries made by the doctor. So in this case, again, it's another ward round, date and time stamp using 24-hour clock. Who is leading the ward round? What's the main problem? In this case, patients come in last night, admitted with central chest pain. So you know what's the presenting complaint. Progress. Some people write, currently patient is comfortable, or this can fall also under your observation and examination. Okay. So they've gone through that same structure. And then this point is quite important to note as well. So this person's written chest x-ray shows bilateral pleural effusions. They've then crossed it out and put in brackets wrong patients and initials. So if you've written in a patient's notes and you realize, oh, I've made a mistake, which can happen, especially you've got, a lot of patients looking after you, kind of mistake the notes or the information being given to you. You cross it out in one straight line. Don't shade, don't color, don't thicken the line. Just cross in one straight line. Point being, whoever sees that crossed off can see what's written under, because again, this is a legal document. And once you've crossed it off, you put in brackets your initials. In this case, is appropriate because they've signed their name underneath and the reason why it's been crossed off. That's just good practice. They've also mentioned, the impression and the plan. Next entry is a discussion with the patient and the wife. So discuss with patient and wife. What was the discussion about? Patient wanted to talk about cardiac risk factors. What was discussed or given? They gave the patient a leaflet about that. Um, and what was the plan? Cardiac nurse will see the patient before discharge, home later. Again, nicely signed. This another entry, review by the F1, no change, TTOs completed, home. This is absolutely perfect documentation. All right. The next one is just an example of a problem list. So you see this, I think, more commonly in medicine, especially frailty, where you have patients coming in with multiple problems. So they don't just, maybe they come in with a fall, but they've also got urine infection that's led to the fall. They've got AF, which they're on, anticoagulation for. They've got previous stroke that contributed to the fall. So these are multiple problems, but are also active in that admission. So in that case, for example, on the ward round where you list problem, You could write problem list or issues or diagnosis, and that's just an example. L- Pneumonia, AF, hypertension, well controlled on Ramipro. So you could put a dash and then put some any relevant information with that. So if you're saying pneumonia, it's good to mention on IV antibiotics or completed IV antibiotics. Again, the point being is that when your colleague comes tomorrow to review that same patient, they know exactly what's happened and they're updated. So they won't be thinking of, restarting antibiotics and then, after 3 hours realizing, oh, but they already had antibiotics. Unlikely scenario, but um, if you understand kind of the meaning behind that is you save time, you you're looking after your patients to the highest standard, of your care, and your documentation is not impeding that. So this is an example of kind of a standard drug chart. This is what we use in Mid Essex as a whole. Most drug charts follow the same structure. They might have, tiny differences here and there. Electronically using these different systems, either on Power Chart or Cerner or EPMA, as I think Bazodon uses, it's electronic. But I'm just going to talk about the paper one because it's quite important what you document on the paper one. So, first and foremost, again, patient details. Don't start prescribing anything without the patient details. That would be my number one advice. Put the patient details first and then do the rest, because the last thing you want is for the wrong patient to get that medication, or without a name or label, it gets thrown away, you can't find a drug chart, things like that. In a lot of the cases, you will have, patient stickers in the notes where you can just stick it on either the drug chart or history sheet or things like that, which it saves you a lot of time, it saves you a lot of hassle. But if you don't have stickers, please don't be lazy, just write it in. So surname, first name, date of birth, NHS or hospital number. Those are kind of the bare minimum. Weight obviously depends on when the patient gets weighed. Address will usually be in the notes. It is good practice to write that as well. And then dates the patient is either being admitted or you're doing the drug chart, the ward they're on, and the consultant. So if the patient changes ward or care of consultant, you should update this as well. And then another very important part of every drug chart on the system, this will usually alert you so that before you can kind of start prescribing, you have to fill the allergy status. On the drug charts, you should do it yourself. So this should be the second thing that you're filling. You can check previous notes, ask the patient directly as long as you find out what's the allergy status. So if they don't have any allergies, we document NKDA, which was on the abbreviations page. That just means no known drug allergies. If it's an allergy, what's the reaction? What type of reaction? So it's good to find that out. And then you sign your name, your signature, and your date. Okay. So just examples of appropriate ways to prescribe. So this is a standard on the left over here is a standard format that you prescribe on the drug charts. So first is what drug is it? So in this case, paracetamol. What route are you administering the drug? Is it oral? Is it IV? Is it intramuscular? Is it subcutaneous? You have to indicate that medication it won't or shouldn't be given without everything being properly filled. What's the dose of the medication? If you've got gram, you could abbreviate milligrams or grams. When you have micrograms, mcg, it's good practice to write that out, because if you abbreviate that, that could be mistaken for milligram, and that's a dire mistake that you just don't want to happen. So again, how often do you want this medication administered? In this case, is QDS. And then it's good to, in most cases, you have to indicate the time at which you want these medications to be had. So in this case, QDS is just evenly spaced out. You can modify it. So if you want the patient having it at a different time, you write that out yourself. The other thing is crossing off medication or suspending medication. So, for example, you have a patient that is coming with hypertension. At the moment, their blood pressure is quite low, so you want to hold off that medication for a particular dose. So it's appropriate to put a cross through the box or put a dash right through the box. Essentially, when nurses administer the medications, they sign into these boxes. So once you've crossed off that box, it means nobody should sign there. Basically, that's what it means. And then they will continue the medication from the subsequent, basically free boxes that are there. If you want the medication crossed or held off for a bit longer, for example, you've got patient warfarin with a very high INR, it's appropriate to put just a line dash through the days that you would like that medication held off, and then it would be continued from this date essentially. If you need to cross off medication completely, then just on the right drug chart, you should cross off. So you've crossed off this entire day and then another line all the way through to the end. Essentially, you've crossed off every box, so there shouldn't be any chance of anyone signing in those boxes. And then you sign or you put your initials along that line just to indicate who has discontinued that medication. Just this example below is unfortunately what you usually see, but um this is not up to standard and it's not appropriate, long story short, because you've done a squiggly line that hasn't crossed off the entire prescription. So if this dose here, where the line doesn't cover, if this dose here is given, the person at fault is you because you haven't actually crossed off the entire medication. Again, these are some issues that you have with paper drug charts. On the system is much more straightforward. You just, click suspend or cancel or discontinue medication. Okay. Usually at the back of the drug chart, you've got that's where you prescribe your infusions, so fluids, blood products, and this is just an example of that as well. You put the volume, any additional drugs or additives, and how fast you want that infusion, and you sign. That I think is usually pretty straightforward. You can always check trust guidelines depending on where you work. This is an example of discharging against medical advice. So the patient needs to sign. They will usually ask you to sign as well, or another healthcare staff. These are obviously you don't need to remember this. It's down to the trust because each hospital might have a different type of form, but they usually use the same format. So patient details. This is an example of a group and save. So for blood cross matching, they always need a doctor's signature, otherwise they won't be processed. Name, signature as well, and yeah, again, it might be different depending on your hospital, but that's generally the format, just so you're, a bit familiar with these kind of things and you're not caught out of the blue. So just some general tips before I, conclude. I think this is that's the last slide. So just a few tips. Documentation is quite broad because you document every day, and I'm sure you already document every day. There's in the NHS, I think what's overwhelming is the sheer amount of forms and different performers or worksheets that you need to use in each scenario. I'm very confident you will learn on the job. Always ask. If you're not sure, ask somebody, ask your colleagues, ask the nursing staff, ask your consultants. And that's how you learn. You will practice. When you do start, I would advise things like, for example, your clerking performer. Just get one, have a quick look through, or even for an existing patient, see how you know whoever's done it has documented through it. Get familiar with it. um get familiar with other types of forms as well, which there's no other way than whilst you're, on the job. But the important takeaway, I think, is to remember that you need to keep these standards when it comes to documentation. When you're doing a ward round sheet, what's important? Who is doing the ward round? When was that done? Who's documented that? What's the plan? Those things need to be very, very clear. So, just a few tips to kind of round off. Make sure your notes are complete. So, don't leave your notes uncompleted. You start it off and you go to do something else. No. Document everything that's happened, any relevant information, and then sign it off. Don't leave some information out. Essentially, that's the take home. Make sure try to write your notes as soon as possible. Sometimes again, this is quite difficult because if you're on call, you see a patient, you get called to an emergency. There's no way to write that note as soon as. But when you do come back, when you do have a chance to come back and document, you can always document written in retrospect. So whoever reads it is aware that you saw the patient at so and so time, but you just documented a bit later. And you can also document why the delay in documentation, so that that's crystal clear. Make sure you document for the correct patient. So double check the name, date of birth, identification number. This has happened to me a few times that luckily I caught myself before signing off. You grab some notes, especially if, let's say, notes have changed folders and you just rely on, it's bed five's notes. Always check the name, look at the labels before you document. Try to avoid too many abbreviations. There's many, many, many abbreviations that we use in the NHS in general when you document, other than very commonly used ones. Try to write everything else out because it makes it easier for everyone else to understand what you're trying to communicate, and vice versa. When you're on the other side of that, it's nice to be able to read something and understand what you're reading, as opposed to being left with question marks. Avoid personal comments. So any offensive or humorous comments, personal comments should not be written. It's not professional. It will damage your professional credibility. The notes are an official document and a legal document. So you can't scribble on them or write anything inappropriate on them. Try to avoid that as much as possible. And make sure your notes are not tampered with. So this was back to what I said about correcting any mistakes on the notes. Don't shade or color in. Just one straight line through. Put your initial so you know who's crossed it out. If need be, the reason for crossing that out, and then that should be fine. And last but certainly not the least, try to make sure your documentation is clear and legible. The stereotype of doctors and bad handwriting is quite a strong stereotype. So let's try to break that, and help yourself, help your colleagues. Just try to document clearly so that they know what's going on. Because at the end of the day, to help yourself and your team provide optimal or high standards of patient care, you need to be able to read what's going on with the patient. That in itself can cause time delays, misunderstanding, and that's what we don't want to happen. So I hope that's been kind of some useful information. If anyone's got any questions, then please feel free to ask. I'll just put some references here for documentation standards. You can read up on that if you ever need to check or check yourself, see if you are keeping with